The surgical anatomy of salivary gland. So, we have your three major salivary gland, which includes your parotid gland, then we have your submandibular gland and your sublingual glands. So, these are your anatomical locations of your three major salivary glands. So, now let us discuss few important anatomy points from this. So, first we have your parotid gland. So, these are ectodermal in origin. Now, they develop in your 6th week of gestation. So, when your epithelial buds invaginate from your oral mucosa into your surrounding mesenchyme, what happens is that a tunnel develops from this groove and the gland is formed at its blind end by your proliferation, budding and extensive branching. Right. Now, the secretory acini develop from this epithelial tissue. So, please remember that your secretory acini develop from the epithelial tissue, whereas your capsule of the gland and the connective tissue develop from your mesenchyme. Now, parotid, unlike other glands in the body, does not become capsulated early to form a regular gland. Right. Now, the other structures in the vicinity, including the vessels, nerves and lymphatics, develop before your encapsulation. Now, they envelop the facial nerve, terminal branches of the external carotid artery, retromandibular vein and the superficial temporal vein and the lymph nodes, and this capsule also merges with the investing fascia from the zygoma over the temporomandibular joint and the masseter and reaches the styloid base, posterior digastric belly and the sternocleidomastoid muscle. Now, the superficial aponeurotic system is also closely approximated to this capsule. Now, why are we dealing so much detail of this capsule? Because of this formation process of the capsule and the involvement, the parotid gland is irregular in shape and wedged in a recess between ramus of the mandible, base of the skull and the mastoid process. So, it is this attachments of this capsule which makes the parotid gland your irregular in shape. Now, the parotid duct. Now, the parotid duct is your Stenson's duct. Now, it passes over your masseter muscle. So, if you look over here, clench your teeth, this prominent muscle is your masseter muscle. So, your parotid duct passes over this masseter muscle and enters your buccal mucosa through your buccinator muscle at the level of your upper second molar tooth. So, in sum, an accessory gland is found along the course of the duct. Now, this salivary tissue that is separated from the main parotid gland is referred to as an accessory parotid gland. Now, they lie on the masseter in front of Stenson's duct and have secondary duct joining the Stenson's duct. Now, the incidence is around 21 to 61%. Now, this embryologically the growing budding salivary glands that originate from the oral cavity epithelium into the mesenchyme as they differentiate into your various facial structures. Now, why is this important? Because the late completion of your parotid gland encapsulation needs to be considered when we plan the surgery for your accessory gland pathology that might also require the removal of your superficial parotid gland. Hence, it is important to know about this accessory parotid gland. Now, following your superficial parotid gland, the remnant encapsulated acinar system in the glandular structure may also account for a sialocele formation, which is a localized cavity or cyst containing saliva. Now, after parotid gland surgery, the acinar system with the ductules can be exposed to the wound, resulting in breakdown and your leakage of saliva with fistula formation. So, if the facial nut gets enveloped within the substance of the gland as it grows laterally, dividing the parotid gland into two parts, which is your superficial and your deep lobes. The major functional component, that is 80%, is your superficial, whereas your deep is usually retromandibular component with your minimal functional gland tissue. So, the lymphatic system develops within the parotid glandular tissue after encapsulation of the submandibular and your sublingual glands. So, what it does is that it results in the majority of the lymphatic structures including the lymph nodes being embedded within the parotid. So, the retromandibular drain which drains this lymphatics generally lies deep to the facial nerve and is a constant landmark that is useful for the retrograde method of identification of your main trunk of the facial nerve. So, the most of the lymph nodes lie in the superficial lobe of the parotid gland lateral to the masseter, while very few lie in the deep lobe of the parotid gland. So, this would be very important during your planning of your surgical removal of your parotid gland. So, please remember the concept of your late encapsulation of your parotid gland and the early capsulation involving the nearby vicinity structures, which would be an important aid in your surgical removal of your parotid gland. Now, coming down to the next, which is your submandibular gland. So, we have the submandibular gland which originates from the junctional tissue between ectoderm and endoderm from the floor of the mouth. Now, they grow from the 18 to 25th embryonic week and acquires connective capsules. They lie in the submandibular space between the digastric muscle and extend upwards deep to the mandible. It consists of a large superficial and a smaller deep lobe that is continuous around the posterior border of your mylohyoid muscle. The deep part of the gland lies on the hyoglossus muscle in close relation to your lingual nerve. Now, why are we reading this? Because this would be some of your important structures that need to be preserved during your submandibular gland excision. Now, the submandibular gland innervates the submandibular gland by your postganglionic parasympathetic fibers from your superior salivary nucleus of the pons through the chorda tympani and your lingual nerve. Now, these ganglionic connections are required to be separated to free the gland and preserve the lingual nerve during your excision. So, this basically emphasizes that lingual nerve needs to be preserved during your submandibular gland excision. Now, this gland is also surrounded by a well defined capsule which is derived from your deep cervical fascia, which splits to enclose it. Now, the duct of your submandibular gland is your Wharton's duct. So, which lies between your hyoglossus and the mylohyoid muscle after rising from the deep part of the gland. It drains the sublingual papilla into your anterior floor of mouth. The facial vein lies superficial to the gland to reach your anterior border of your mandible, and this facial artery enters deep to the posterior belly of the digastric and the styloid muscle and passes through a superficial gland to reach the anterior border of the mandible. So, these two are very again important landmarks while you go for your dissection of your submandibular gland. The glandular branches needs to be ligated when preserving the facial artery during your submandibular gland removal. Then we have your facial artery, which is commonly used as a recipient artery in microvascular anastomosis and free tissue transfer in head neck reconstruction. So, it needs to be preserved. Hence, it is important to know the course of your facial artery, because if we injure it, we might actually remove one of the options that would be available to us for your free tissue transfer. Then we have another nerve, which is a marginal mandibular nerve lying in the superficial fascia traversing over the facial vessels. Now, there is a technique which is devised by Martin, right, of ligating these vessels and flipping them above in order to preserve the mandibular division of your facial nerve during your neck dissection. So, again this is another important structure that needs to be preserved during your submandibular gland excision. Now, coming down to the last parotid gland. So, we have your sublingual salivary glands, which is your sublingual gland. So, they contribute to around 5% of your saliva production and are the smallest of the major salivary glands. They lie above the mylohyoid muscles below the floor of the mouth, as we had seen in the image at the beginning of our discussion, right, and are bordered by the mandible laterally and by the genioglossus muscle medially. Now, the secretions are drained by the duct, which is your revenous duct, that exit along the sublingual fold at the floor of mouth. Now, there are few anterior ducts which may join together to form a common duct called your Bartholin's duct. So, please do not get confused with the name. Parotid has your Stenson's, submandibular is your Wharton, and your sublingual is your Revenous duct or your Bartholin's duct, which empties or closes into the Wharton duct near the sublingual caruncle. Now, the pathology of the sublingual glands mainly involves the formation of your mucous attention cyst, which is the ranula, and the tumors of this glands are very rare. So, this were the few important points with respect to your three major salivary glands with respect to your surgical anatomy.